The residents who are going to present will display the, those skills of clinical examination, of history taking. So let's start with the first. There are three, so whoever is ready can go.
Good evening, everyone. I'm so thankful to everyone giving me this opportunity to speak about my case over here. So, coming to my case, my patient is Mrs. I, 49 years old housewife with no prior comorbidities, headache for 3 months, bilaterally diffuse, dull aching in nature with frequency of once in a week, with a severity of 4 by 10, not interrupted daily activities, and except she feels tired after work for some time in standing posture. No specific exaggerated or relieving factors. So there is no progression for a period of 3 months. But after 3 months, on one fine day when she was in a prayer, so she had a sudden severe intolerable headache. She never had such severe headache. Initially in the occipital region, later became diffuse with a severity of 10 by 10. This was not associated with any disturbances in conscious level, no associated vomitings or weakness in the limbs. This headache not responded to the oral analgesics, for which this was persisted throughout the day and disturbed her life, for which she was admitted and noticed to have normal vitals and NCCT brain reported as normal, for which received injectable analgesics, and she had partial relief from the pain. And she was discharged on day 3 with 2 analgesics and amitriptyline. So at home, she noticed that her headache used to worsen within 15-20 minutes of standing and relieving in 20-30 minutes after lying down positions. She prefers to lie down all the time as she felt severe headache while she was doing activities and affected her activities of daily living. She could not focus on interactions that were happening at home, and for which she required analgesics thrice daily, otherwise she could not tolerate her. No history of trauma, fall, assault, surgery, LP procedure, or nasal discharge, or nose blockage, or congestion in the eyes, nose. No photophobia, phonophobia. She never had fever and normal vision. Now, past personal family history is not significant. So coming to the symptom analysis, she's a 49 years old lady with 4 months history of headache with moderate severity, which was holocranial, initially non-progressive for 3 months, followed by sudden severe headache with postural variations that worsens on supine positions without any altered sensorium or vomiting. Sir. So from the symptom analysis, so I consider the likely possibility of the secondary headache. From the huge list of secondary headaches, I consider the following 5 headaches with postural variations like cervicogenic headache or POTS or colloidal cyst, and the post-surgical causes and spontaneous intracranial hypotensions. Coming to the cervicogenic headache, there are some diagnostic clues like headache associated with flexion rotation movements of the neck, restricted neck movements, and provocative movements like flexion and rotation movements leads to appearance of the symptoms or worsening of the existing symptoms, and dissociation of the cervical lesions like trauma, and the resolution of the symptoms with the treatment of the cervical lesions. Either it is a unilateral or bilaterally symmetrical, which was actually not there in my patient. And there are some image clues for the cervicogenic headache like cervical root or cord compressions and spinal canal narrowing. Coming to the POTS, postural orthostatic tachycardia syndrome. If you look into the picture on the right hand side, so there is a once the patient stand up, there is a increasing in the heart rate more than 30, and without any fall in the blood pressure. The diagnostic criteria also tells the same thing. There is a sustained increase in the heart rate more than 10 in the standing position, and reproducibility of the symptoms with every time when the patient stands up, and absence of the orthostatic hypotension. Sir. There are 3 subtypes like neuropathic or hypovolemic or hyperretinesic, and it is important to know the subtype also, as the treatment varies in the 3 types. So there are cardiovascular symptoms like lightheadedness, palpitations, exercise intolerance, and syncope, and a few non-cardiovascular symptoms gives you a clue is like fatigue, anxiety, tremors, nausea. And tilt table test, autonomic function test, and thyroid function test will helpful in the diagnosis. And the colloidal cyst, I consider this because in this case also there is a postural variations of the headache. This is a slow-growing mucus fluid filled cyst. 1% of the intracranial mass lesions and 20% of all intracranial intraventricular mass lesions. Common locations are anterior roof of the third ventricle at the foramen of Monro. If you look into this picture over here, this is the frontal horn of this lateral ventricle, and this is the third ventricle. The junction at the junction, this is the most common site in the sagittal and coronal view. So if this is a benign cyst, very slowly growing. Most of the time, this is asymptomatic. If there is a rapid growth of this colloidal cyst, there could be a possibility that there is an obstruction bit of the CSF flow from the lateral ventricles to the third ventricle, leads to hydrocephalus and enlargement of the lateral ventricles with normal third and fourth ventricle. And the headache, the postural headache is because there is when the patient stands up, fluid and the pressure rises and headache worsens, and that relieves on the lying down position, sir. And there are some other symptoms like raised ACP symptoms like nausea, vomiting can be associated. Here the picture shows that this is a colloidal cyst at the junction of these frontal horns in the third ventricle and leads to the enlarged lateral ventricle, sir. And the Kyrie malformations like problems at the foramen magnum and cerebellar tonsillar herniations. Like if you see the pictures, there is a cerebellar ectopia and even the distal medullary ectopia. These are Kyrie 5 malformations. And the symptoms support suggesting symptoms like worsening headache, coughing, sneezing, and other symptoms like tingling, numbness, and several other problems at these locations could lead to similar complaints. And the last one is spontaneous intracranial hypotension. When there is a dural CSF leak, majority of the leads to secondary to trauma. And the headache is classically, there is a postural variations, which I already explained, that appears in 30 minutes of standing and relief in 20 minutes of lying down positions. Some image supportive features like subdural fluid collections, meningeal enhancements, engorged veins, pituitary hyperemia, and sagging of the brain. These are the same image findings. This is the meta-analysis published in the last month. Most common is the diffuse pachymeningeal enhancements followed by the venous engorgements and then brain sagging and enlarged pituitary gland. Coming back to my patients, she had normal vitals and normal blood pressure, normal heart rate and blood pressures in supine and standing position with normal cognition and higher mental functions. Cranial nerve examination is normal, no papilledema, normal sensory motor and cerebellar examination, sir. So when we do a CT at the first presentations, there is a thin subdural collections and the slit ventricles and then effaced ventricles, which were actually missed at the presentation, sir. And the MRI was also suggesting the subdural collections and the slit ventricle and effaced ventricles. When there is a post-contrast T1 image showing diffuse pachymeningeal enhancements and the other similar findings which I mentioned. So in the spine imaging, there is a long column of the CSF leak along the dorsal-lumbar spine, and there is a leak at the lower border of the T3 level. So we proceeded initially tried with bed rest and the caffeine, which was not helpful. And the specific management about the blood epidural plus 20 ml was in the patient's own blood was injected into the epidural place with 24 hours rest and started her activities at the day 2. And she was mobilized at day 4 without any symptoms. So after she followed up once in every 3 months for over a period of 1 year, and her analgesic requirement was decreased, and she doesn't require any epidural patches. And in the repeat imaging was also showing there is no active CSF leak. In the meta-analysis, in the pooled symptom analysis, the most common symptom noticed was orthostatic headache. In the image findings, the most sensitive was MR myelography, MR and digital subtraction myelography in the lateral position is most sensitive to pick up the exact specific site. CT myelography is picks up the high flow leaks, and MR myelography can detect the low flow leaks. MR myelography is with feature sequence is a T2 weight sequence with long TRT and 3D volumetric study, high sensitivity specificity to detect the exact locations. In the treatment and outcomes, majority 75% failed the conservative managements. There is no subgroup analysis. About the specific managements, 60% has a successful rate with the first epidural plus, and the similar successful rates with non-targeted as well as targeted epidural blood pressure closure. So small blood pressure closure is done with less than 20 ml, and large EBP was done with more than 20 ml. So coming to the last 2 slides, sir, there are some possible misdiagnoses because as there is a cerebellar tonsillar ectopia can mimic like Kyrie malformation, subdural collections can mimic like subdural hematoma, and pachymeningeal enhancement may be confused with meningitis. Sir. And the conclusion is consistent postural headache in standing position should have high suspicion about the SIH. Early and exact identification of the CSF leak that leading to its closure gives you the better results. And the primary aim in the management is closure of the CSF leak rather than its sequelae. And the complications you should keep it in mind are CSVT or subdural hematoma and then cerebellar tonsillar herniations. You should keep it in mind. And your primary aim should be management of its closure rather than its sequelae. These are my references, and thank you very much for giving me this opportunity to speak about my clinical. Thank you very much.
Thank you, Govinda. Just want to go back to your list of differential diagnosis. I mean, yes, it was the worst ever headache. So straight away, there was a red flag about a secondary cause. But for you to begin with cervicogenic headache for such a catastrophic presentation, I would argue with that. So I think, to stick to, and in fact, even though there was a normal CT scan, whether this patient should have had a CSF, because that kind of severe headache at the onset suggests that something had happened. So I don't agree with your first differential diagnosis being a cervicogenic headache. But yes, very interesting, and thank you.
Thank you, madam. Thank you.
Yes.
A very good evening